Right, my name is Elizabeth McCarthy and I'm going to demonstrate the safe execution of synchronised cardioversion. In this scenario we have a patient, 55-year-old male. His chief complaint is chest pain with collapse today. His history was acute onset of chest pain with a collapse following dizziness. His past medical history is hypertension, ischemic heart disease, previous MI 5 years ago. On arrival, the patient was lying supine on the floor. He was pale and clammy. His eyes were open to pain only. His voice response was only to pain, and he's not obeying commands. His medications are Cilazapril and aspirin. The vitals that we've gained from this patient are a heart rate of 170 with a 12 lead showing a wide complex ventricular tachycardia, as we can see on the monitor. His blood pressure is hypotensive at 70 on 40. His resps are 24. He's short of breath. His blood sugar is 7.6 and his temperature is 37. Treatment so far, we've positioned the patient supine on our bed. We have administered oxygen. We've gained bilateral IV access wide bore and we have fluids running. We are also preparing for resuscitation with our bag valve mask, our airway adjuncts suction, and we have placed pads on his chest. Provisional diagnosis at this stage is ventricular tachycardia or VT with severe cardiovascular compromise. He is severely hypotensive, he's unable to obey commands, he's short of breath, he looks status 1 and is at high risk of cardiac arrest. Differential diagnosis that I'd like to quickly discuss and rule out are SVT with aberrancy, such as a bundle branch block. That is more likely in a younger person, and with his cardiac history, I'm not thinking that that's what we've got today. Sepsis again is something to consider. However, we've found no signs of infection and he is afebrile. Tricyclic antidepressant overdose could also cause a wide complex tachycardia like this. However, he's not prescribed these and the history doesn't really fit in with that situation. Finally, I'd like to consider electrolyte imbalances such as hyperkalemia. However, given the history and his medications, I'm not thinking that's the case today either. Before we consider cardioversion, we need to make sure we don't need analgesia or sedation. Because our patient's not obeying commands, we don't need to consider that today. However, if he was alert, we could call clinical desk and get permission to administer ketamine. In that situation, we obviously have to ask the patient's consent as well. So now, using the challenge and response, I will complete the cardioversion checklist with my crew partner.
Place pads in either apex sternum or anterior posterior position in addition to the ECG electrodes.
So as we can see, apex and sternum pad placement, ECG is also in place.
Ensure the defibrillator is in manual mode.
The defibrillator is in manual mode, as we can confirm.
Select a lead with a visible R wave and ensure that artifact is minimised.
So we've got no artifact and I've got a lead with a good visible R wave.
Select synchronised mode.
Selecting synchronised mode now. There we go.
Confirm there is a detection symbol above every QRS complex.
So I can see there is a detection symbol above every QRS complex. I will just print a rhythm strip to confirm. Yep, that looks excellent.
Ensure the patient has received adequate sedation if this is indicated.
As per our assessment, the patient is not obeying commands. Can you squeeze my hand? No change there.
Select the joules, charge the defibrillator and confirm everyone is clear.
So I will charge the defibrillator at maximum joules, 360. That's charged. Checking everyone's clear.
Press and hold the shock button until the shock is delivered.
Okay, shocking now. Shock delivered.
Determine the rhythm and level of cardiovascular compromise.
So at this stage, I'll reassess my patient's ABCs and response. I found no change in his level of cardiovascular compromise or his response. So at this stage, I can now administer one further synchronised cardioversion. If that's unsuccessful, I'll transport the patient towards R50 backup or hospital, whichever is most appropriate at this stage.